Today I have the honor of being joined by Dr. Jill Ingenito, and she is a DO specializing in pelvic pain. So she is a physician who has dedicated her career to helping people with endometriosis, generalized pelvic pain, and other causes of pelvic pain, and she's going to share with us what her practice is like, how she helps patients manage their symptoms, and why she loves Intimate Rose products so much. So she will join us shortly, and if you have any questions as you're rolling in, please don't hesitate to put them in the comment section here. It's always a treat to be joined by different types of practitioners who share different methods, because as we've seen, people have different ways of managing and everyone responds differently to different treatments. So we are so lucky to be joined by her today. There she is. We're gonna pull her in. Hi, Jill. So while she's getting pulled in, welcome to everyone who's rolling in. If you have questions on endometriosis, pelvic pain, be sure to pull those in. Hi, yay, it's so great to see you.
Same.
Thank you.
Thanks for having me.
Oh, thank you so much for coming on. I love how passionate you are about helping people with endometriosis and pelvic pain. Do you want to start by telling us about your practice and how you manage patients?
Sure. So I'm actually a general OBGYN, but in the last 7-8 years, I've kind of geared myself towards managing chronic pelvic pain. There was a huge gap and there is a huge gap just nationally and globally, but there was a huge gap in our group. And so someone kind of needed to step in and take the reins. And there was thankfully a mentor kind of already doing it, and she was able to kind of bring me along. So, so most of what I do is, I would say over 80% is managing chronic pelvic pain. The majority of that is going to be endometriosis, adenomyosis, and pelvic floor disorders. I do still do some labor and delivery just to keep my skills up, and some other just basic OBGYN. I was actually on call for 24 hours last night. So if I seem a little bit slurred, that's why.
Understandable.
Yeah.
Sleep deprived.
Yeah. So I still do kind of the basic stuff, and I still love seeing my OB patients, but most of what I feel like where I can help the most for people is actually in the chronic pelvic pain space, in the endometriosis space. So when people come to see me, I do a consult with them. I actually evaluate for all reasons why you could have pelvic pain. So I kind of cast this broad net and then kind of narrow it, whittle it down. Definitely the two most common things that I see are endometriosis and pelvic floor disorders. So we kind of start with either medical or surgical endometriosis, and then I get everyone connected with pelvic floor PT. So that, and it's so interesting because I think before I got into this space of chronic pelvic pain, I don't think I referred anybody for pelvic floor PT, and it's crazy. And now it's like, it's hard for me not to find somebody without a pelvic floor issue, to be honest. So,
it's really in one way or the other. There's a lot of different ways that it can present. So I love hearing that you've changed your practice pattern. We've worked really hard as pelvic physical therapists to gain the trust of our colleagues that are physicians and to ensure that we have seamless care. So I'm so glad to hear that.
Yes. And it makes such a difference. I'm always just like, please go. They will help you. They will change your life. I promise you. Come back and see me after you've had like 5 or 6 sessions and we'll regroup. And yeah, I mean, the number of times that I've heard it completely changed my life is numerous. It's endless. So I'm so grateful, because honestly, without that piece of the puzzle, like especially for endometriosis and for other pelvic disorders, like people would not get better. Like they just wouldn't. So I'm so grateful that we have great ones that we contract with. We're really lucky.
That's wonderful. And where's your practice located?
So I'm with a large health group in Denver. I'm originally from the Midwest, and I practiced up in the mountains for a couple years, and then I moved with this large group in Denver.
Love it. I went to PT school in Denver at Regis University.
Okay, awesome. Great.
Denver was home for a few years, and I loved my time there, and I miss it very much.
And where are you now?
I'm in Oregon.
Okay.
Very similar.
Yeah, it's a great city.
Yes. So I'm 1 in 10. I have endometriosis. And one of the things that I find in my patients is the wide presentation of endo. Mm-hmm. Some people have a ton of bowel problems, and some people have very little, and it's more focal towards the bladder or the pelvis. Can you share with people the myriad ways that a patient with endometriosis might present to you in your clinic, for them having probably no idea what's happening with their body?
Yeah, and that still sometimes happens. So when people come in, like I always ask them, so what do you think is going on? And what is one thing I can help you with when you leave here and feel like this appointment was worth your time? But people still don't know about endometriosis.
No.
It's really shocking. And so I would say, I think I kind of go in with sort of this hat of like, almost everybody has endometriosis that's going to see me, because it's the most common thing for chronic pelvic pain. So I kind of go in with that, like, you need to convince me in this appointment that you don't have it. Because if you've taken the time, you've seen multiple doctors, you're here to see me as a specialist, like, it's very unlikely that you're walking in here without it. So yeah, I mean, I would say there's quite a few different things. The classic thing is just this horrific periods. Lifetime suffering, teenage years. Sometimes it's actually, people have been on birth control their whole life, and then they have their kids, and they're like, oh, my husband's going to get a vasectomy, and now I'm going to stop my birth control, and I'm in my 30s, and what the hell is this? So that I do see not uncommonly. I do see quite a few teenagers, and it's just so great to catch them at the beginning and kind of be able to say, hey, this is what it is, and guide them. I do see a lot of patients with bladder issues. And so in that kind of situation, it can be urgency. Sometimes they're waking up in the night 4 or 5 times. They're voiding like 18 times a day. They have pain with sex. So sometimes in that situation, I'm kind of like bladder endo, interstitial cystitis, pelvic floor. And so I do see a lot of bladder stuff. And so that's something I screen for on the questionnaire that we have people fill out. And I always tell them, like, the treatment for all 3 of these actually is pelvic floor PT. There are other things that we can do to treat these individually, but we definitely got to start with PT and see what component of your pain is coming from there. I would say it's pretty uncommon for me not to see people with, the typical like IBS symptoms, or they've been told they have IBS, and almost all of them have bowel and bladder dysfunction. So yeah, those are kind of the main thing. It's pretty remarkable. I do find also quite a bit of coexisting history of sexual trauma. So we always screen for that as well and get people connected with mental health. But yeah, almost everybody has these horrific periods and bowel and bladder dysfunction as well. There are occasionally, those cases where you see, you don't expect endometriosis, where we're going in there for some other reason. Like, let's say somebody, is having a hysterectomy for some reason other than pelvic pain, could be just bleeding or stuff, and you get in there and there's horrible endometriosis. Those I would say are less common. Most of the time though, I would say, it's just a long history of painful periods, bowel issues, bladder issues, recurrent UTIs, IBS, all the things. So we kind of take a step back and say, okay, is actually this endo? Are all these things really connected from your pelvic floor and endometriosis? Probably. Yeah, probably.
Absolutely. And I think that's such an imperative question to be asking and to be looking for, what was previously thought of as a zebra, a rare occurrence. We're looking at symptoms, and we hear hoof prints. For those aren't aware, we would 9 times out of 10 expect to see a horse and not a zebra. But I think these zebras are coming up more and more, and I don't truly believe that it's 1 in 10. I think that the incidence is significantly higher, and just people are undiagnosed for a very long time. And one of the things that I had come up in a conference that I was at is that some physicians don't understand the presentation of endometriosis when they're in laparoscopically and they're seeing different colorations, that they don't know that endo can present with the different colorations depending on the genetics and the age and all of those different factors.
Yeah, that's one of the biggest problems I see actually presently with the physician community is that, I mean, you have to learn so much in the 4 years that you do residency. And there's just such a push to become proficient in obstetrics and proficient in all things gynecology and just be safe, you know? So you get some exposure depending on where you train. You get exposure to chronic pelvic pain, but unless you have a chronic pelvic pain specialist that you work with on a rotation, like I would say even like once or twice a year for 2 months, like you're just not gonna see enough. I just there's so much to see and do. You know, you got to go through oncology and you have to go through REI and infertility training and all these things. Like there's just I just don't feel like there's enough exposure in most residency programs for people to kind of see, okay, these are all the different presentations of what it can look like. One of the most common things I see, which is super unfortunate, is people having a laparoscopy, the OBGYN or the gynecologist looking in, doing a kind of a survey, but you really have to look very, very, very close. Like, I mean, I assume that it's going to be there and that I just need to find it. And so there are some cases where I'm like, okay, this really does look stone cold normal. So I still don't trust the visual inspection. I would say more than 50% of the time, I still see endometriosis come back on the pathology. So now I've gotten into the habit, definitely in the last 8 years, and this is something my mentor taught me, is like, you always take biopsies, regardless. Like, you're in there, you are taking biopsies behind the uterus on the peritoneum where endometriosis lives. You take out a big section there and send it to the pathologist, because I've like for sure more than 50% of the time the pathology report will say endo. So it's just shocking because it's like I'm like, I didn't see anything, but let's just wait. There's two possibilities. It's either coming back on the path or you have more severe adenomyosis. So that's kind of an unfortunate. I just had a couple consults actually 2 days ago where it happened to two different patients, and I'm like, I still think this is endo. They just didn't take any biopsies. So it's unfortunate, and I think we really need to move that needle, like in training. I mean, these are people that I work with, like, so I'm still trying to move the needle out of our organization. Like, if you go in there, you must put at least 3 reports in and take biopsies behind the uterus. So it's just, you know, it's hard because these people, like, they've seen multiple doctors, and then one's like, yeah, you might have endo, and they do a laparoscopy and they're like, it looked totally normal, but I didn't take any biopsies. I'm like, oh, okay. Okay. So it's actually a really unfortunate thing, and I see it very commonly. So I do think,
Oh, go ahead.
what'd you say? I do think it's important that when you have the laparoscopy the first time, that you have someone who's a specialist in the area and knows that. And there just aren't enough of us. But I do think that we'll move the needle at some point, and that it will be routine standard of care to take a peritoneal biopsy and at least like 2 or 4 different places, because we're missing it. So.
Always safe than sorry. And so when you do get that patient, are you offering to go back in and take another look?
Good question. So I will. I give them all the option. I'm like, I am not your mom. Here's your options. Like, you decide how you want to run this show. These are the different pathways you can pursue. For a lot of those women, if they're still bleeding and still getting periods, I usually will start with kind of a 12-week course of suppressing their period altogether. And then almost everybody hasn't done pelvic floor PT. So I usually say, let's do 12 weeks, no bleeding whatsoever. However you want to get to the no bleeding point is totally up to you. But we do 12 weeks, no bleeding. You're in pelvic floor PT. You're going every single week, and then you come back to see me. If you come back to see me and you're like, this isn't working, we're going back in, doing the laparoscopy, and we're taking all the biopsies, which just take out the whole backside of the peritoneum behind the uterus. But I also tell them, like, listen, if I go in there and I take all that out, like, and it comes back normal, my plan doesn't change for you. You still have horrible periods. You still have pelvic floor muscle dysfunction. I still don't recommend that you get a period, and I still recommend pelvic floor PT. So yes, you might get some pain relief, and I'm happy to do that. But like, at the end of the day, like, not going to say just forget everything if you're doing better. So it's interesting. And then, a lot of people in that situation, I'm also like, do you want to do an MRI in the next 12 weeks and see if you have adenomyosis as well? Even if the MRI doesn't show it, you still might have it. So it's kind of, it can be challenging. But yes, I give them the options. I'm like, we can do a laparoscopy tomorrow, or we can do this kind of medical treatment, rehabilitate with PT, see what progress you make, get an MRI, and then go from there. I give them the choice. It's hard because they've been through so much that it's like, I hate to be like, you have to go this way or this way. I'm like, I'm not your mom. You guys decide what you want to do.
And what they're up for at that stage, because it may be that they cannot be down for those couple weeks because of work, but maybe 6 months down the road they're feeling ready and they can come back to you and say, let's get back in there, let's do this. And 12 weeks of pelvic therapy is super fair. That's a really fair start. We should expect to see some decline in symptoms, even if they're 100% goals reached or those things, because especially with chronic pelvic pain, we might be having treatment in pelvic PT for 6 months, but we should have a really fair start with 12 weeks to be making progress towards those goals, be seeing some relief during certain activities, sitting, intercourse.
Yeah. And I just like to hear back from the PT and then see what they think. And then also like the patient is more able to discriminate. Oh, this is my pelvic floor pain that I didn't even know I had a pelvic floor. And this is my more endo pain. Yeah. So, and I would say 9 out of 10 times when those people come back in 12 weeks, they're like, I'm not bleeding. I'm okay. And I'm doing PT. I'm going to keep it with the PT. I need to live my life right now. I'm like, that's great. Whatever you want to do.
Someone had a question here. I'm going to scroll through. Let's see. Do OT, so occupational therapy, help at all with pelvic floor therapy? Do they play a role in the healing journey? Absolutely. Pelvic floor occupational therapists. So occupational therapists have different training. We work very similarly, but we have a different framework, and occupational therapists are doing a marvelous job in pelvic health therapy. They are often found working collaboratively in the same clinic as pelvic therapists. They are opening their own clinics as well. So super grateful for our colleagues that are occupational therapists. And then I think there was another question about, is there any way as a PT to help advocate to convince the necessity of biopsy? Ooh, this will be a good one for us to discuss, because it's such a tender line of requesting something from a physician or advocating for your patient, where if we're getting somebody and we suspect endometriosis, or we suspect that additional medical management is needed, certainly it warrants a phone call, if not a meeting, but we want to be so careful about what we as physical therapists say. So can you give us some language that might be helpful if we suspect that a physician might do good service to our patient to do a biopsy?
That's tough because, and I hate to say it, and it could be, it's definitely going to be the culture of where you work and who you collaborate with. So that's part of it. I would say the best thing that the PT could say is, hey, if you had a laparoscopy and they didn't see anything, it would probably be of benefit for you to get a second opinion from somebody who does more endometriosis, more pelvic surgery, because they're going to know to take biopsies. But is a general OB/GYN going to take a biopsy? I have no idea. To be honest, when I wasn't doing chronic pelvic pain, like 10 years ago, I didn't do it. And that's just the way it was. So like if I had a PT, I'm trying to think, if I had a PT come to me and be like, you need to do biopsies, it's like, I'm open to anything. Like I don't have like a lot of barriers, but I'm sure I do, just being a physician to the PTs. But I feel like it would depend on the setting, honestly. But I do see a lot of patients who will come, they've been to PT and then they'll see the PTs that I work with, and the PT will tell them to come see me or one of my other pelvic pain colleagues, so we know to do the biopsies. I think it's just worth a conversation. I think I would say you might want to have a conversation about whether biopsies were taken or not, and just ask the doctor if, hey, if you don't see anything, I know that endometriosis can be there. Could you still take a peritoneal biopsy behind the uterus, uterosacral ligaments, anywhere? And at least send a sample for pathologist to review. So I think that's probably the way, is kind of to just gift the patient with the language, like ask your doctor about a biopsy. And if you haven't had one, then ask them to do another laparoscopy with a different doctor who will do one. So yeah, it's tricky. And like, and sometimes the PTs actually have fantastic ideas. Like they'll come back to, the patient will come back to me, oh, the PT recommended that, we add vaginal estrogen, or try a pudendal block, or try Botox in this muscle or whatever. And I'm like, yeah, I'm up for that. Totally. Whatever they think is going to help, they're the pelvic floor experts. But I definitely have had some where I'm like, ooh, they're going a little rogue on that. Yeah, on that. Like I had someone the other day, it was like, and I loved this PT, but she was like, just tell her to do a pudendal nerve block, and that will tell you how much relief you'll get with a hysterectomy. And I'm like, for endo, I can't completely agree with that. It's possible, but I'm not going to say like the block I'm going to do in the office is going to be 100% copy and paste what results you may see with a hysterectomy in somebody who wants one, So I'm open, but I have seen not all pelvic floor PTs are the same. There are so many good ones, but I've learned they're not all the same.
100%. And training and perspective and personality all come into play. And it's really important that we be well trained on our, and it needs to be in place. Yes.
Thankfully, the two groups that we mostly contract with at the organization I work with, they have really, really good ones. What I find though is like they get so built up in the practice that they're in, and then they all leave and go start their own private practice where they can be more profitable. So there's definitely not enough pelvic floor PTs. Definitely not, at least where I live, there's not enough.
It's likewise here too. I think it's an ongoing problem. And the funny thing is I started pelvic PT 16 years ago, mm-hmm. and I had a few hundred in the country, and there wasn't enough then. And now we've got tens of thousands here in the U.S., and there's still not enough, because now we are working much more collaboratively. Patients know what we're offering more readily, and we just got to get more trained up. We got to do more.
I know. I don't know. I sometimes tell my endometriosis patients, like, who've gotten really significant relief, I'm like, maybe if you don't know what you want to do with your life, like, consider pelvic floor PT therapy. Like, I don't know if you have any interest, you know what I mean? Like, you've done so well. Like, if this has changed your life, like, would it be something you're interested in as a career? But
I started, I was the patient on the table.
Yeah, I'm always trying to sell people. I'm like, this is like actually a great career. And you help so many people. But yeah, I get it. Like, it's like the more people learn about it, especially like through social media and online, it's like they're so slammed. So
about pH imbalances, could burning in the vulva be related to the work you do in your office? So how do you test for pH imbalances, and then how do you manage it medically?
Yeah, good question. So we just actually use regular old pH paper in the office, but now they have all these like fancy over-the-counter tests, and I always see these advertisements on Instagram, like you can check your pH, and we actually have the ability where I work, like people can just come in and check their pH and swab themselves, and then we can kind of get them the results so they don't have to go through a pelvic exam. But yeah, I mean, I just use a pH paper in the office and kind of see, are we acidic, are we basic, are we neutral, what's the story? And then go from there. But yeah, I mean, so if the pH is off, you always want to think a couple things, like what's the estrogen status? Like, are we deficient in estrogen? And then also, is there an infection or like a bacterial imbalance that's causing the pH to be off? So do we need to treat for that? Definitely gals who've had chronic vulvar, vaginal infections or chronic pH dysfunction, they start to have just some changes to the surrounding tissue in the vagina and the vulva. Most of what it is like just the skin isn't necessarily a great barrier anymore. It's just not super healthy. And so like stupid things like wearing a swimsuit for 10 extra minutes or staying in your yoga pants like for an extra 30 minutes, so you can stop at the grocery store and get bananas, can really throw off it down there, whereas like somebody who has more healthy vaginal vulvar tissue and adequate estrogen is able to do that. So they get triggered a lot by the really stupid things, and the pH imbalance goes off. So usually there's a role for estrogen there. But in those tissues, then what starts to happen is like the nerve endings just start to become hypersensitive or start to feel different, like different things they would. So normally, like if you touch someone, let's say with healthy skin on the vulva, and they're like, oh yeah, you're just touching me lightly with one finger. What I start to see is in those tissues that have had chronic infections and the tissues aren't super healthy, when I touch them in a certain place, they feel like I'm poking them and jabbing them with my nail or a sharp instrument. And so that tells me like the nerve endings have adapted and not in a healthy way. Yeah. And so then they just have this chronic, they can have this chronic burning and vulvar pain in the vagina and on the outside. And it can be a little tricky, unfortunately, to treat, but usually like, we're eradicating any pH imbalance and any infectious causes like for like a year. And then really treating with the hormones, estrogen and testosterone are probably the two that I use. I will also inject those nerves too to get people relief. And also topical steroids can help too. Thankfully, where I work in my clinic, there's a gal who did like a vulvovaginal fellowship overseas, and she is in my clinic, and so we kind of brainstorm and and we kind of share some patients there. So, but it's like such a blessing because I've learned so much from her. But yeah, I would say like it can be challenging. Usually once we get like the pH restored, it's a lot of work to keep it there. So making, screening for early infection, making sure we don't get to the point where we have really severe disease, making sure estrogen and testosterone creams are used, and then adding other therapies like injections. There's topical pain medication that we can use too. But yeah, those can sometimes be challenging.
Question I get a fair bit is if topical estrogen is prescribed, do they balance it with progesterone? Because there's been a lot of dialogue about unopposed estrogen. So can you help educate?
Yeah. So the levels that you're absorbing from the topical estrogen down there are not going to get in a high enough concentration to risk other areas of your body, right? If you're putting in your mouth or you're putting on your skin, the estrogen, those levels are going to be much higher in your bloodstream and affect your tissues way differently. And that's where we can see estrogen by itself start to cause problems like cancer. So by mouth or on a patch, you need progesterone on board. Topical is just it's not enough to cause any issues. I mean, I have occasionally seen like people who I have like twice daily dosing of estrogen vaginally sometimes have like some breast changes or nipple soreness, and I'll usually just take them down to once daily dosing or every other day dosing, but it doesn't appear that what we know that has any long-term or harmful benefits from just topical estrogen, which is nice, especially because we can use it like in our breast cancer patients. So we'll still use topical estrogen in them, even if they have hormone receptor positive breast cancer, because there's just nothing else that can save their vagina.
Yeah.
So we're lucky with that. But yeah, no, you do not need progesterone for topical estrogen.
Love it. Somebody is asking if you have colleagues that are like you in Ohio.
I do not. There is a network, and I'm trying to like, people ask me this actually a lot, and I need to sit down and look at it again. But there is like a pelvic pain network, and you can get to IPPS, which is the International Pelvic Pain Society, and they have like a directory, and most pelvic pain providers go to that conference, and they will at least hopefully be linked on there. So if you can find anyone through the International Pelvic Pain Society, IPPS.org, then you can find them and see who's in Ohio. But in a large metropolitan area, you should be able to find one. Rurally, I don't even, it's just like, I'm in Denver. I work at like a place where there's a million physicians and there's probably 300 OBGYNs and there's 3 of us that do it. But like I used to work in a rural location in the mountains here in Colorado and there's no one. It just doesn't exist. So I'm trying to remember what I used to do. I think I used to send people to the university here to see a pelvic pain specialist. But most universities, that's the other thing, most universities now have somebody who does pelvic pain, and they should be able to connect you and kind of be the, kind of get you connected to the right people to help you, the pelvic floor PT, or if you need surgery, or if you need, pain management. The university settings, they should be able to.
Yes, totally agreed. And I'm a clinical member of IPPS.
Okay.
For endometriosis, in terms of finding care, Nancy's Nook.
Yes.
Nancy is a nurse who's been advocating. She's such an incredible human. She's got a list of surgeons and physicians who have demonstrated training and knowledge and skill specific to endometriosis. So Nancy's Nook, she's on Facebook. Yep. Got a website. If you ever get to be in her presence and hear her speak,
I have not, and I would actually love to. And I don't know that I might not be on that list, but I know one of my mentors. I know one of my mentors is, and so usually if they're trying to see her, then, and she's kind of phasing out of her practice, they'll say, okay, here's who's taking over, and that's usually how they will find me. But yeah, that is also a great resource, Nancy's Nook. I know a ton of people who found great providers on there. Thank you for thinking of that.
Yes. Someone is asking if you could please discuss testosterone replacement options and the best form.
Sure. So I would not say I'm a testosterone expert, but I know a little bit about it. So actually the main thing that I use the testosterone cream for is for people who have vulvodynia, like the vulvar pain or vaginal pain that's just really resistant to treatment. So I find that I can get some help with the estrogen cream, but then I need to also give them a testosterone cream down there, and I have found that helps. There are multiple ways though you can get testosterone. I think the most common way that I see people do it is with those pellets. It's not something that we offer at our at the clinic or the organization that I work at, but obviously I just ask, like, if people try standard hormone replacement therapy, they try estrogen and progesterone and they're not getting relief with what we have on formulary, then I'm like, hey, here's someone you could see outside of our organization and they can easily talk to you about your testosterone options. But yeah, definitely the most common thing I see is the testosterone pellets. I think that's and probably the easiest way to take it. The only thing I've seen with that is, you really have to be, because part of testosterone gets converted to estrogen, right? And so then if you're just taking the testosterone and some of it's going into estrogen, now we're back in that situation where we have not a way to balance with progesterone. So that's pretty uncommon. Like it's only seen like one person who was doing testosterone pellets and no progesterone. I have had a few situations where they've had, they're doing the testosterone pellets and they had a Mirena IUD in place for their progesterone, and this person actually still got cancer, unfortunately. But that's the biggest thing is, like, I kind of find that most of the providers are pretty savvy and put people on progesterone if they're on the testosterone pellets. I do think we need more like testosterone products that we can use. But yeah, that's a little bit outside of my lane, unfortunately. Just because there's people that are really good at it that I know. And so I kind of let them kind of rein that and kind of stay within the pelvic pain range. But I do hormone replacement therapy. I just usually start with the standard, either transdermal patch estrogen or oral estrogen and oral progesterone. And then if they're like, yeah, my symptoms are still, I'm like, you might see results with testosterone. Talk to this person. It's going to be out of pocket. But if it's affordable for you and you feel better, who cares? So the biggest thing is just that you have someone that puts you on progesterone.
Perfect. Yes. And there's a new growing sub niche in OB-GYN of NAM certified people. So people that are just doing menopause. Yeah.
Thank God.
So we're moving forward.
Thank God. Because, it's just like the pelvic pain is just like a whole, like, I can't be good at everything. That's the thing.
Yeah.
Like I'm not good at everything. But I am kind of keyed in on the endometriosis and pelvic pain, and that's kind of where the space that I try to focus on. But I do find like, once I kind of get a little bit more down the path of hormone replacement therapy, I'm like we're getting a little bit outside of where I would recommend listening to what I'm saying and where I would recommend you maybe see another doctor. So we have great hormone doctors, so that's great.
Yes, that's really good to know yourself, and we can't all do all the things. So you're providing a tremendous service, because endometriosis is another area we need more providers. So
I actually think we need like a full fellowship. So, we have like the minimally invasive gynecological surgery fellowship, the MIGS fellowship. And so that kind of came on the scene as I was finishing. There was like very few when I was finishing residency, and there's a lot more now. But I don't think I don't know. It depends on the fellowship, but I do think a lot of those fellows, like, they spend most of their time in the OR, which is a great place and what you need to learn. But so much of managing pelvic pain is not in the OR. So it's kind of, I feel like we need like a pelvic pain fellowship that's dedicated to part MIGS and then part like the surgical training, and then also part like, how do we manage these people, right? Because I've seen people that have had all kinds of surgery and everything cut out, and they're still in horrible pelvic pain. I'm like, yeah, like I had a MIGS surgeon take out everything and I'm still in pain. I'm like, oh, have you ever been to PT? No. Okay. Not all pelvic pain is fixed in the OR. So I just think there needs to be like more education around that, more residency training, more a fellowship that's dedicated to pelvic pain and not just the surgical management of pelvic pain.
agreed wholeheartedly.
And cutting out endometriosis in the OR can be very challenging, but it's also really challenging when you have somebody who's had everything cut out and they're still in debilitating pain.
Absolutely.
So that can be equally challenging.
Absolutely. And that's where that team,
yeah,
where we all help.
Exactly. So yeah, there's definitely clinics that are more set up that way now, with like a surgeon and a general surgeon and the PTs and like somebody in PM&R and all the things. We need more of those. And they need to be more readily available. Like, people shouldn't be flying all over and going to other countries to have this. Like, that's crazy to me. That I'm like, oh my God, where did you go to have what surgery? And yeah, you got relief for like a year, but now we're kind of back, so a lot of it's in the office and working with the patient like as a whole, and not just looking at them as like a surgery case.
The person.
Yeah. Yep.
Well, thank you so much for coming on. Is there anything else you would like people to know about your work?
No, I just appreciate you having me. I'm just trying to spread the word, and that's why I started this Instagram this spring, was because it's crazy. I mean, I still hear people like, I've never heard of pelvic floor muscle dysfunction. No one's ever known what's going on with me. I've been to the ER a million times. All my ultrasounds are normal. I've never heard of endometriosis. I'm like, what is happening? Like, I live like a large metropolitan city, and like, these are educated women, who like, I'm just like, so I'm like, and every time people walk out of the office, they're like, I wish I would have found you sooner. I wish I would have heard this message sooner. I wish I knew about this sooner. I'm like, how are we not getting to these people? So that's why I started it, because I hear the same things, the same questions over and over, the same statements over and over. And I'm like, okay, I'm just going to try to get this out here on a broader spectrum.
Absolutely. And you're doing a tremendous job at it.
Thank you. I love your work too.
Thanks.
I send everybody, I'm like, you need this wand.
Yay!
And actually, I think most of the people in our organization use the Intimate Rose. They mostly refer to the Intimate Rose one. Yeah. They mostly refer to that one as kind of our go-to for pelvic floor help. And it really, I'm like, you got to be doing this with your weekly PT, and you're at home and you're doing this. And so, and even for some people like who are resistant to going in person, they're able to learn enough where they can use the wand at home. And that's been super helpful too, just because they don't like people touching them. They don't want to go in. It's embarrassing. I don't know. But that tool is really helpful.
Oh, thank you so much. That makes my day. That's what it's there for, is to help empower people to get better faster and get better independently in conjunction with their management. And as a means of after discharge, because that is a goal, is that people are going to feel ready and empowered to be managing their symptoms without pelvic therapy. Certainly, they need to be going to their annual exams and seeing their physician, but we're always here for them if they flare up, but they need to live their life outside of appointments. So
Right.
the wand intended as a tool to help get them there faster.
It's awesome. Thank you.
Thank you so much for sharing
You're
your
welcome.
time. I appreciate you so much.
You
And
are welcome.
I hope to see you at a conference very soon.
Awesome.
All right.
Sounds good. Thank you. Have a great rest of your day.
You too.
Bye.
Bye.